Hello, and welcome to the Alabama Public Health Training Network. Glad you can join us for this program. The Affordable Care Act, mandates, exchanges, Medicaid, and all that. Our objectives today are to describe the definition and application of the individual mandate, explain the definition and implementation of the large employer mandate, describe the role and function of the health insurance exchanges, and to state the purpose, cost, and impact of the Medicaid expansion and discuss why states may not participate in the Medicaid expansion. If you have a question about anything being discussed today, please call or email our faculty presenter during the live broadcast. Our 800 number and email address are on the screen now and will appear again throughout the program. Also, the handouts, sign-in sheet, and evaluation for this program are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for both nurses and social workers for this program. The ADPH is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive credit for this program, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is October the 22nd, 2013. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. ADPH does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. The Alabama Department of Public Health is now charging viewers who are not employees, contract employees, or retirees of the ADPH for CE certificates. More detailed information and specific instructions can be found on our website. Registration and participation in live and on-demand programs will continue to be available at no cost. Today's program is produced by the Alabama Public Health Training Center. If you'd like more information about the center, you can visit their webpage listed on your screen. Let's meet today's faculty presenter, Michael Morrissey, professor at the University of Alabama School of Public Health. Welcome, Professor Morrissey.
Thank you. I'm delighted to be here. It's a good time to be talking about the Affordable Care Act. It's all come alive this month. So what I want to do is to spend the next hour basically just walking through some of the issues, looking at questions of the subsidies that go with the individual mandates, the penalties for not participating, and sort of working through how the exchanges are supposed to facilitate all this. In the process, we'll spend a little bit of time talking about sort of the challenges that exist in trying to set up those exchanges. Then we'll shift gears and we'll talk about the Medicaid expansion, what it's supposed to do, the number of people that are supposed to be covered, the nature of the costs, the sorts of revenues, and we'll use Alabama as an example of sort of what potentially is available. Then we'll also talk about sort of reasons why a state may choose not to expand their Medicaid program. Finally, we spend a little bit of time talking about sort of how all of this is supposed to be funded. And then we'll have probably about a half hour to answer your questions and go into some more detail as things come along. So in terms of an overview, we'll start with the individual mandate. As Samita said, we'll talk about the employer mandate, the exchanges, Medicaid, and so on. The place to start, I think, is with sort of what is expected. And the numbers on the screen come from the Congressional Budget Office from their March 20th report that was 3 days before the Congress passed the legislation. So this is what the Congress thought was going to happen at the time they voted for the legislation. And what the CBO estimates is that there were approximately 50 million uninsured folks in the U.S. That as a result of the Affordable Care Act, what we should see is a dramatic reduction in the number of uninsured. The programs begin to phase in beginning next year in 2014. The CBO estimates that there would be some 19 million folks who would pick up coverage through one or another of the expansion elements, but we really don't get to sort of steady state till about 2016 and thereon, because it takes time for people to sort of understand what the program is, realize that they should be participating, taking advantage of the subsidies and so on. So these are the estimates from just as the Affordable Care Act was enacted. In fact, we won't reach these numbers. We won't reach these numbers because a number of states have chosen not to expand their Medicaid program or are delaying the expansion of the program. So these were, in many ways, sort of high-end sort of estimates of what was likely to happen, certainly in the 2014 period, and we'll see what happens going forward. But the first way that we begin to reduce the number of uninsured is by the individual mandate. Basically what it does is it requires that most U.S. citizens and legal residents, those who've been here 5 years or more, have to have health insurance. There are penalties for going without coverage. There are subsidies for lower income folks. And there's a requirement for having qualified coverage. The idea is, or the concern is, that people might sort of buy something that's health insurance in name, but in fact doesn't sort of provide any coverage. So or adequate coverage. So the law specifies the nature of the coverage that is supposed to be there. Importantly, what happens with the individual mandate is it eliminates pre-existing conditions in insurance contracts. So if one has diabetes or heart condition, what would often happen in the individual insurance market is one would be quoted a higher premium, or one might be denied access to coverage. What the Affordable Care Act does is allow those people to buy coverage at the same price as everyone else. The implication of that, though, is that those higher cost folks are going to be averaged in the same risk pool with everyone else. And so while their premiums are likely lower because they're able to get this coverage, people who don't have pre-existing conditions and are younger are likely to see that their premiums are going to rise. So while some people gain, some people lose, in terms of premiums at least. There are also penalties. The problem is if you're going to put everybody in the same risk pool, and some people are going to pay less and some are going to pay more, you've got a problem that insurance types worry about called adverse selection. The fear is that only the sickest folks would join. And in fact, the sort of the extreme case of that is since you could, in principle, sign up any time, why would you ever buy coverage today? And since they can't charge you a higher premium if you're sick tomorrow, why not wait till tomorrow to buy coverage? So in that sense, ideally what you'd perhaps like to do is as they're rolling you into the hospital on the gurney, you would like to sign up or have somebody sign you up into the Affordable Care Act. And then as you are wheeled out to your car in the wheelchair after the successful treatment, you would disenroll. So to try to prevent that, what the legislation requires is that there be a phase-in of penalties, so that if you choose not to have health insurance, that you'd pay a penalty. Now, these penalties sort of are phased in over time. You've undoubtedly heard the number $95 per year as the penalty. That is the penalty in 2014. The more important number, though, isn't that $95 per year. It's or 1% of your income, whichever is higher. So for most folks who are facing this, it's not going to be that 95. It's going to be 1% of income. By 2016, we're talking about 2.5% of income. So if you're someone who has a family income of $50,000, the penalty in 2016 is going to be something like $1,250. The premiums aren't as high as some of the insurance types who pushed for the legislation had wanted. But they're high enough to be a consideration, and indeed these penalties get adjusted going forward for cost of living. So penalties to keep people enrolled in the program. It also turns out, as certainly the press has made abundantly clear in the last 2 weeks, that there's an open enrollment period, and that you're allowed to enroll during the open enrollment period, but typically not afterwards. That's another mechanism to limit the adverse selection. Because if you don't get the coverage during that period, not only do you pay the penalty, but you don't have access to the coverage until the next open enrollment period. So that, in addition to the penalty, gives people sort of pause if they choose not to take the coverage. There are subsidies. The way the subsidies work are through the idea of the subsidy is that there are lots of folks who aren't able to afford the coverage that's available to them in the exchanges, and the way the subsidies work are through the tax system. And basically, what's to happen is there is to be a tax credit. For example, if a tax credit is $1,000, what that means is if you had health insurance that cost $1,000, your tax liability would be reduced by $1,000. That's what a credit does. It reduces the tax liability that you would have to pay. And that's all well and good, but suppose you don't have that kind of income. Well, these subsidies are refundable. What that means is even if you didn't have income equal to the amount of the subsidy, you would still get the subsidy in the form of a refund on your taxes. That's all well and good too, but if you have to get the health insurance in January and you fill out your taxes the next year in March or April, that really doesn't help a lot in buying that coverage. And so the subsidies are advanceable. What that turns out to mean is you will go to the health insurance exchange and they will give you an estimate of what your subsidy is likely to be. You'll use that subsidy, that estimate, to buy coverage. The exchange will directly pay the insurance company that's offering the policy that you chose. And then next year, when you fill out your taxes, you're going to put in the amount of the estimated subsidy, and you're going to fill in your real income numbers and all of that. And the tax forms are going to say, the subsidy that was estimated was just exactly what it should have been, or maybe the subsidy was a little bit too great and you owe some more taxes, or the subsidy wasn't quite large enough and you'll get a refund. But it all works through the tax system. And it's designed to allow people to get coverage today and sort of do the accounting cleaning up when you file your taxes. Now, the subsidies are on sort of a sliding scale. If you have relatively low income, subsidies are fairly high. If your income is between 100 and 138% of the federal poverty line, you are eligible for a subsidy that says you have to spend no more than 2% of your income on health insurance. If your income's higher, as you can see on the slide, you have to pay more of your income before you reach the threshold. If your income is in the neighborhood of 300 to 400% of the federal poverty line, you're still eligible for a subsidy, but that subsidy is available to you only after you've paid 9.5% of your income towards health insurance. So the amount of the subsidy sort of declines as your income rises, and above 400%, you're not eligible for a subsidy. So the obvious question is, so what's the federal poverty level? The federal poverty level changes every year, and it depends on your household income and the number of people residing in the household. So I've put together a number of values for the poverty level for 2013. If we look at, for example, a household with 2 people, 100% of the federal poverty line is $15,500 and change. Up to 400% for that 2-person household, income could be as high as $62,000. Now you may have heard numbers about sort of being able to get a subsidy up to $94,000. That is indeed true. You get that's for a family of 4. And 400% of the federal poverty line there would be just over $94,000. The amount of the subsidy you get is rather modest at that point, and indeed might not exist. Let me give you an example. So what I've done with the graphic that's on the screen now is we've got those income levels that I just talked about, the level of the federal poverty line from 100 to 138%. In the next column, I've got the income range over that period. So for that person, 100 to 138%, it's 15,500 to 21,004 for a family of two. So that's those same numbers that I talked about a moment ago. The most they would have to pay is 2% of their income. So I took the midpoint of that range at 2%. That would mean that they would be eligible for a subsidy of $4,631. And that would go towards the purchase of a health insurance plan. So as income rises, as you see, the subsidies get smaller and smaller. And in fact, what that sort of suggests is, for somebody in that lowest rung of 100 to 138%, for a $5,000 health insurance plan, they would have to pay $369 a year. For that same policy, as their income rises, they pay $780 if they're in that 138 to 150%. And as you see, the subsidies get smaller as their income gets higher. And way in the bottom in the corner there, it says no subsidy. That's somebody who's in a household of two people. They have an income between 300 and 400% of the federal poverty line. They have to pay 9.5% of their income before the subsidy kicks in. Well, if indeed the health insurance plan costs $5,000, as I suggest there in the last one, 9.5% of their income is more than the cost of the health insurance plan. So there's no subsidy for them. So there's sort of really two features of the subsidies that go on. One is what your income is relative to the eligibility for the subsidy, and the other constraint is how much the health insurance plans cost. And what the law says is they have to base that cost of the plan on the second least costly silver plan. Bear with me, we'll get there with what that means. So in this case, I just sort of assumed that might be $5,000, which is what the price of individual coverage for employer-sponsored health insurance was in 2012. So it's in the ballpark. So lots of subsidies that decline actually pretty rapidly as your income rises, but subsidies available for lots of folks. That's the individual mandate. There's also a mandate for large employers. Large is defined a little bit generously, perhaps. Employers with 50 or more full-time employees must provide health insurance or pay a penalty. So it's called a pay-or-play mandate, the idea being either you pay the penalty or you play by offering health insurance to your workers. The penalty is $2,000 per worker after the first 30. So if you had 60 employees and you weren't providing health insurance, the first 30 don't count against you, but after that you would pay a penalty of $2,000 per worker for those next 30. There are sort of two issues that sort of revolve around the employer mandate. The first is that definition of what constitutes a full-time employee. The convention among lots of employers historically has been to define full-time as 35 or 40 hours. The legislation doesn't do that. The legislation defines full-time as 30 hours or more. So what that means is there's a group of employers who have heretofore employed people for 30 hours, 32, 33 hours, and not provided health insurance, but under the law they're now required to do so. And so what we've seen in the press are sort of a lot of anecdotes about employers sort of changing sort of how they make employment decisions. So somebody who may have been working 30 hours, now they're going to be sort of, their work schedules are going to be changed such that they work maybe 25 hours. And the idea being they'll employ more part-time workers, fewer hours per worker to avoid this sort of new 30-hour requirement. That's affected or appears to affect a lot of folks in the restaurant and service industry. It actually turns out to have a pretty big effect on universities as well, particularly those that hire a lot of adjunct professors. how many hours they work has been a little bit vague, but now universities have to come to terms with that. They have to come to terms with research assistants and teaching assistants and how many hours they work and where they're going to go. So there are both large and small employers and employers in a variety of different industries sort of affected by the full-time, part-time decision. Having said this, though, the second big issue is, with the exception of that full-time, part-time thing, we really shouldn't expect the large employer mandate to have much of an effect in the labor market. The argument is that as an employer, I pay people essentially what they're worth. We all like to think we're worth more, but so we're pretty much paid what we're worth. But we can get paid in a variety of ways. So there's this compensation basket that has money, wages in it, and maybe it has health insurance in it now. Well, the stories we've heard is that employers will simply say, well, I'll stop offering health insurance. I'll take that out of the bundle. I'll pay the $2,000 penalty per person. Health insurance costs at least $5,000, so I'm money ahead. But that sort of ignores the nature of the labor market. If you're working for what you're worth and you're currently being paid money, wages, and health insurance, and now they're going to take the health insurance out and give you nothing back, you're worse off than you were. And the best of us are going to go look for a job somewhere else. So that makes it difficult for an employer to actually sort of change the compensation bundle. So it's unlikely that many employers are going to drop health insurance. If it made sense for them to do it, they could do it last year and this year, take out the health insurance, give you higher wages and other benefits, and be done with it. After the Affordable Care Act goes into effect on January 1st of next year, they'd have to and they chose not to offer the coverage. They'd have to take the insurance out of the bundle, put something else in there to make you as well off, and pay the penalty. The economics just don't work in most cases. So most large employers are going to keep offering health insurance, with the exception of the full-time, part-time issue that is sort of the other issue. The thing to appreciate with the other thing to appreciate with the large employer mandate is that this mandate's been delayed, where almost everything was supposed to start happening on January 1st of 2014. The implementation of the employer mandate has been delayed till 2015. Much of that has to do with the difficulties of getting the exchanges working properly. It's hard enough to get them working in the individual market, as we're seeing in the last 2 weeks. It's even harder in the group market. Having said all that about the large employers, we should talk about small employers. Small employers have less than 50 employees, and they are not required to offer health insurance. There's nothing in the legislation that says they have to. There is a subsidy available to small employers if they have less than 25 workers, but that subsidy only lasts for 2 years. And so, frankly, we don't expect to see many small employers beginning to offer health insurance coverage, at least as a result of that subsidy. It's just not there for long enough to matter. And what research we know about the small group market is one thing small employers don't want to do is offer health insurance and then have to take it away. And if they only do it because of the subsidy, it's unlikely they'll continue to do so. Now, I do think that there is some action that's going to happen in the small group market that's pretty important. And I think what happens is, let's suppose that you're a small employer, 40 employees, 30 employees. You currently do offer health insurance. And it's the case that most of your employees are relatively low income. They'd be eligible for subsidies in the exchanges, as we just talked about a few moments ago. Well, from that perspective, it can make a lot of sense for that small employer to say, look, I'm not going to offer health insurance anymore, so I'm taking that out of the compensation bundle. I'm going to pay you more. I'm going to raise your wages. And then I'm going to help you sign up for health insurance through the individual exchange where you can get a subsidy. So I make you whole for your employment activities by giving you higher money wages, and we get you enrolled in the individual market with a subsidy. Now, that only works if I'm already offering you health insurance and your incomes are low enough to be eligible for those subsidies. But I think we'll see a fair number of small employers kind of making that doing that analysis and choosing to drop the health insurance they're offering. So we've got the individual mandate and we've got the employer mandate, which drives much of the incentives for the expansion of health insurance coverage. I mentioned at the beginning that you had to have qualified coverage. Well, what constitutes qualified coverage? The legislation says that there are to be essential health benefits. There are 10 of them, and there are broad categories, as you can see on the screen, things from ambulatory patient services, hospitalization, prescription drugs, et cetera, et cetera, et cetera. There are 2 points with respect to the essential benefits. The first is the Congress did very little more than state what they were in these broad brush sets. How much hospitalization? How generous are the prescription drug coverage? Those sorts of things. And we'll define that a little bit in a moment. But the second big thing that goes on here, look at that fourth bullet that says maternity and newborn care. Most employers that offer health insurance provide maternity benefits. In fact, there's federal legislation from 1979 that requires most employers to do that. But it's not required in the individual market. And if you were to go and buy individual coverage last year or the beginning of this year, you would typically find that maternity coverage was not included. You could buy it as a rider if you were willing to pay extra. It's required now. So that's another one of these instances that sort of cuts both ways. If you're interested in maternity benefits, they are now included in the individual coverage that you can get and all rolled into that coverage. If you're not interested in maternity benefits, you're still buying them. So for some folks, they find that this is a good deal and coverage that they didn't have available to them at these kinds of prices before, and others that now they have to pay for maternity benefits that they're not going to use. And you could probably make a case for a number of these others as well, but the maternity benefit is the most obvious one that says there are things that work both ways here. But back to that first point about these 10 sort of broad essential benefits. What we expected to see happening was that Secretary Subsidies at Health and Human Services would sort of put together a committee who would spend a fair amount of time over the last 2 years or so sort of hashing out what constituted the definition of each of those 10 areas. They didn't do that. What they did was they gave the states the options to consider a variety of different plans that were available in the state and to make their own choice as to what constituted the definition of essential benefits. One of the options was to use the benefit package that was the most popular by enrollment of the small group plans offered in the state. There were 3 other options, but most states chose this one, and indeed, if you were a federal default plan, you had to choose this one. In Alabama, what that meant is that Blue Cross Blue Shield Plan 320 was the benchmark. And so what that means is you could go to the Blue Cross Blue Shield website, you could pull up Plan 320, and you could see the nature of the coverage. Now, if you do that, sort of ignore what it says about deductibles and copays and coinsurance and all that, because that's not where the action is for purposes of essential benefits. What you want to do is look at, well, what does hospitalization mean? Does it mean that I'm covered for 365 days? Does it mean I'm covered for something less than that? What about prescription drugs? How generous is that? What's the nature of the number of physician visits? How does mental health work? It's the benchmark plan in each state that defines what are the essential benefits in that particular state. And so we've gotten there, and the states have somewhat more discretion, certainly more discretion than many of us thought would happen as all of this started to roll out. Okay, so you realize that you have to have coverage, and in fact you're looking forward to this, and you're looking forward to whether or not the coverage you might be able to get through the exchange is better than what you currently have. Well, what the legislation requires is that there be benefit tiers, sometimes called medals levels, because there are bronze, silver, gold, and platinum kinds of coverages. All of the benefit tiers from bronze through platinum all include those same essential benefits as defined by the benchmark plan. So each of them have exactly the same sort of coverage in terms of services. What differs is how much you as a consumer pay out of pocket and how much the insurance company pays. If you were to choose a bronze plan, which would be the cheapest, what you're going to find is the insurance companies have to pay 60% of claims costs. And that's based on their actuarial expectations of how much claims are going to be. That means you're on the hook for, as the consumer, you're on the hook for 40% of the claims. That means you might see a big deductible plan, you might see plans that have modest-sized deductibles and big copays, that sort of thing. And you say, well, I don't really want to be on the hook for 40%. I'd like a more generous plan. Well, then you can have a silver plan. You could buy a silver plan. There, you're only on the hook for 30%. The insurance company is responsible for 70% of the actuarially expected costs. Similarly, gold and platinum, if you want very generous coverage, you would want to buy platinum coverage, where you would have to pay 10% of the expected claims costs. The insurance company picks up 90%. But obviously, as you move up the levels here, much as you move up in sort of Delta's frequent flyer plan, the amount that you pay out of pocket here is, the premiums are going to be higher. The amount you pay out of pocket is less. So let's say you want gold coverage. What you would typically see then when you went into the exchange is you would see each of the carriers that were offering coverage, and you would see that some of them are offering, all of them actually, would be offering gold coverage, and a single carrier may offer 2 or 3 gold plans, some of which have big deductibles, and once you satisfy that, very small copays or coinsurance. Others may be designed to have very small deductibles but big copays and coinsurance, and so you would sort of choose a plan that worked for you. But knowing that you either pay sort of on the front end or the back end, depending on whether you want a high premium that gives you low out-of-pocket costs or a low premium that potentially gives you high out-of-pocket costs. And it turns out that carriers don't have to offer every metals level. If they're going to be in the exchange, they have to offer at least 1 silver plan and 1 gold plan. They can offer multiple plans. It's also worth pointing out then that how the carriers are going to compete for your business in the exchange is they basically can't compete much on the way of the benefits offered, because they're exactly the same. They can compete on the size of the deductibles, on the copays, on the premiums that they set for each of these, and on the adequacy of the network of providers that are available. And if you've watched the press over the last month or so, you know that it's claimed that some of the insurers offering coverage through the exchanges have very narrow provider networks. What that means is they don't include lots and lots of hospitals that are in your town, for example. They may include just a handful. They don't include all of the specialists and all the primary care docs, or maybe not even half of them. But they have a network that sort of meets the requirements, but it's narrow. And the reason for being narrow is what they're essentially doing with their providers is trying to say to them, look, I can assure you of some volume in exchange for a lower price. And so a narrow network means that the insurers that are offering these plans are attempting to offer more volume to providers in exchange for a better price. And if you have a narrower network, you can more easily sort of channel your volume to that provider or that set of providers. So that's what's emerging out of the exchanges. So what's going to happen? The CBO estimates with respect to the exchanges are that in this first year we should expect about 7 million people to enroll. I think those are generous estimates. By 2016, CBO is estimating something like 19 million people in the exchange. There's 330 million people in the U.S., so we're talking about relatively modest numbers. Still big in terms of the individual market, but most folks aren't going to be participating in the exchanges. These are some numbers that come from folks at the University of Minnesota. We really don't know, at least we certainly didn't know last year, what a platinum, gold, or silver plan would necessarily look like. But what they did was to look at the kinds of plans that are out there and say, well, this looks pretty generous. Let's think of that as a platinum plan. This is almost as generous. Let's think of that as a gold plan. On the other hand, this is a relatively modest plan. Let's suppose that might be a bronze plan. And so they've done that, and they tried to look at what the coverage looked like in 2012, and from some simulation work, what they think it might look like in 2014 when the exchanges are up and running. Their estimates were that what we might see is about an increase in enrollment in the individual market, in the exchanges and otherwise, of about a third, 38%. With the bigger increase coming in the platinum, gold, and silver areas. So the sense being, there will clearly be an increase in the individual market. Will it expand by a third or 38%? Probably not. Certainly not in 2014 would be my guess. And in fact, I think the estimates of 7 million people in 2014 is really optimistic. And I think we're more likely to see 5 or 6 million people actually end up being enrolled. And that's assuming the glitches are largely dealt with. Okay, so that's the kind of coverage that's available to us. That's the nature of the subsidies. That's the nature of the penalties. What are these exchanges, and how are they supposed to work? Well, an exchange is just a marketplace in which individuals and indeed small employers are able to purchase insurance. The ACA requires that there be an exchange or a marketplace for individuals to purchase coverage and for small employers to purchase coverage. The small employer mandate exchange is called the SHOP exchange, Small Business Health Options Program. Don't ask me why, it doesn't seem to. But in any event, there's an individual market and a small group market. How do they work? Well, it turns out that the states have a fair amount of flexibility with respect to what they want their exchange to do. And there were 3 general kinds of models that they could follow. The first is called a market facilitator model. There, the idea is what the exchange would do is accept all the plans that sort of meet that definition of a qualified health plan. So they're offering the essential benefits. They're meeting the definition of the benchmark in that particular state. They've got adequate network access. And there, what happens is the exchange then sort of serves as a neutral source of information. You come to the exchange, they lay out what all your options are, and you decide. That 45 on the slide says that there are, in fact, 45 states that have chosen to take the market facilitator approach. Chosen is perhaps not quite the operative word, because if you were a federal default program where the state chose not to implement its own exchange but to use the federal exchange, as Alabama and all of the states in the Southeast have done, they're required to use the market facilitator model. The second approach is what's called a selective contractor model. The other 6 states took that approach. What it does is it says that the state is going to look at what those qualified plans look like, and they're going to add other kinds of requirements. Maybe they're going to say, well, the deductibles can't be any larger than X, or they may require that the networks be broader in terms of the providers that are there. They may require additional kinds of services that are offered. Some 6 states have taken that approach. The third approach is called an active purchaser. None of the states yet have done that, although states can migrate one direction or the other if they choose to, if they are state-based exchanges. An active purchaser is sort of like a large employer. And what an exchange would do in that circumstance is it would say, well, we're going to negotiate with various carriers. So we're going to talk to United Healthcare, Humana, Aetna, Cigna, Blue Cross, and we're going to solicit bids from them, and we're going to take some of the offers and not all of them. And we'll negotiate hard on price and other dimensions of the product. And once we've done that, we're only going to offer the plans that we've negotiated a contract with to people who buy through the exchange. So in some sense, the exchange in that role sort of plays the role of an active purchaser, sort of buying the coverage and then making it available to all of us. But as I say, so far no states have taken that approach. I suspect that if things go well over time, some states will move in that direction. So what's an exchange supposed to do? It turns out that it has an awful lot of things to do. First of all, it's supposed to determine eligibility. So it's the case that I may be eligible for Medicaid, and we'll talk about Medicaid in a few minutes, but I may be eligible for the new expanded Medicaid. The exchange is supposed to tell me that I'm eligible. In some states, like Alabama, that has a separate CHIP program, it's also called All Kids. The exchange is also supposed to tell me that my kids are eligible for that program, and it's supposed to be able to tell me if my kids are eligible for existing Medicaid as well as the expansion, and it's supposed to be able to tell me whether I'm eligible for a subsidy, those things we talked about earlier, and how big that subsidy is going to be. So they have to determine eligibility. That turns out to be a big deal. How many people live in your household? We have to know that because, and how much income does your household have? Meeting the definition of income in the Affordable Care Act. So we know how big the subsidy that might be available to you is. We have to know where you live because we have to know which plans might be available to you. We have to know the ages of your kids, because that would tell us whether they're eligible for existing Medicaid or maybe for a freestanding CHIP program. So there are a variety of things we have to know. Do you have coverage through your employer? If you have coverage through your employer, then you're not eligible for the exchange subsidies, at least under most circumstances. And as a consequence, so the exchange have to do a lot to determine eligibility. Then they have to actually enroll you. So you've signed up. And you've said, I want the silver plan being offered by, Aetna. Okay, so we sign you up, and we sign up your other members of your family. If you're a small business, we sign you up as well. There's some particularly difficult issues, because what was supposed to happen in the exchange in the small group side of it was the employer could say, well, I want to offer a single plan offered by Blue Cross, and it's going to be a silver plan. And so I've chosen the plan, and that's what my employees are going to get, much as small employers do today. Or I choose the silver level, and they can take any silver plan they want. Or I choose a carrier, Humana, and they can choose any plan within that. Or they can. I will let them choose any carrier, any plan. That turns out to be sort of more than the exchanges could handle in this first year. And so one of the first things that happened in terms of delaying the exchange was to delay the requirement that small businesses, that the small business exchange have that whole range of options. So in this first year, the only thing that's available is one carrier, one plan. As part of the enrollment issue, you have to worry about disenrollment. I've moved away. I didn't pay my premiums. My income got a whole lot different. They're supposed to disenroll me. And so they have to be able to sort of keep track of all of that. They have to know that I didn't pay my premium and deal with the provisions for that. There has to be sort of an appeals process if something has gone wrong. And so the exchanges are supposed to be able to sort of deal with all of this in virtually real time. Then there's plan management. The exchanges are supposed to certify the plans. That is to say, yes, you're offering the essential benefits. Yes, it meets the benchmark requirements. And so we can certify that this plan is eligible to be offered in the exchange. the exchanges are supposed to give quality rankings of each plan. How good is this plan relative to various benchmarks? They're supposed to review the marketing to make sure that it's fair and appropriate. They're supposed to review network adequacy to make sure that there are enough providers and that they are distributed well enough to sort of service the volume. All of that's a responsibility of the exchange. More than that, they're supposed to provide consumer assistance. There's supposed to be a single application. So if I show up on the website, if I call in, if I go into a storefront office, there's one application, and it gets me into Medicaid if that's where I'm supposed to be. It gets my kids into the CHIP program if that's appropriate. It gets me into the exchange with a subsidy if that's where I'm supposed to be. All of that is supposed to happen through a single application. I'm supposed to be able to make plan comparisons. Now it is probably pretty obvious, I'm kind of a policy wonk here, so I sort of think of the plan comparison thing as what an Excel spreadsheet might look like. That you go in and they list sort of all of the benefits that are offered and at what premium and what the deductibles and the copays are for the various silver plans that are being offered, for the various bronze plans, and I'm supposed to be able to make those comparisons because it's laid out very nicely for me in the exchange. And then there's supposed to be a premium calculator so that I can figure out how much I'm going to have to pay. And then there are to be, and the term of art is navigators, there are supposed to be people who can help me get through all of this. These could be employees of the exchange. They could be people under contract through the exchange to provide that kind of assistance. They're not supposed to tell me that this is the plan for you, but they're supposed to tell me that this is what a deductible means. This is when it says you get 40 days of coverage here, that's what that means. And notice that if you compare this plan with that plan, that the deductible is different and the premium is different. So the navigators are supposed to facilitate all of that. That turns out to be a big deal, even for those of us that have had health insurance for a long time. If we had insurance through an employer, we didn't have to know much about this. Maybe they offered us 3 plans, and we didn't have to know a whole lot to be able to choose which plans. And in the individual market, most of us have never played in that sort of market. So, there's a whole lot of education to be going on here to make people informed consumers, even given how well things are supposed to be laid out in the exchange. Finally, there's an issue of financial management. What the exchanges are supposed to do is they're supposed to deal with risk adjustment, and I'll come back to that in a second. They're supposed to deal with payment of plans. You chose the Cigna plan. Okay, well, they're supposed to make sure that the money flows to Cigna, that they get it and they get the subsidy. Essentially, you would pay Cigna for your share of the premium, and the subsidy would come through the exchange. Risk adjustment. Remember at the very beginning we said that pre-existing conditions weren't supposed to matter. And what that means is, in some sense, what you'd like is every plan has a random draw of the population, and they all look pretty much the same, and the claims experience is all pretty much the same in every plan. Well, that may work out that way, but it may not. It may be that for some reason, the sick folks disproportionately join my plan. Maybe it's because I've got this great cardiologist who happened to be part of my network, and so I attracted a whole lot of folks that have heart disease because they wanted care from her. Maybe it's that the network I've got is disproportionately in the suburbs, and so it attracts young, healthy folks with kids, but not older folks. What the exchange is supposed to do is all of those people are supposed to pay the same premium given their ages. But if I'm an insurer and I get a whole bunch of sick folks, and Samita's an insurer and she gets a whole bunch of healthy folks, what's supposed to happen is the exchange is supposed to say, well, you shouldn't get all of the premiums that you were going to get because you got a healthier draw of the population. So some of the monies the premium dollars that you would have gotten go over to me because I got the sicker draw of the population. Risk adjustment. So the exchanges have to deal with all of that sort of behind the curtain. And then finally, there's the issue of exchange solvency. In the first year of operation, an exchange, the exchanges, the cost of running the exchanges was dealt with by the federal government. After that, though, the state's on the hook for the entire cost of running the exchange. So, what to do? Well, what the states ended up doing is that 26 states decided to let the federal government run it. 18 states said that they would be state-based, and 7 states said that they would use a partnership model. I think the surprise isn't that so many states went with the state default. I think the surprise is more states didn't. Because the issue was, first of all, open enrollment was, as we all know, supposed to start and did start, sort of, October 1st, with fully functioning exchanges on January 1st of 2014. The federal guidance was slow to arrive. And if it turns out that, and after the first year, come 2015, the state is on the hook for the cost of running the exchange. So from that perspective, that sort of looks like the potential for a real sort of lose circumstance from the point of view of a governor or a legislature, particularly as it turned out when the federal default exchanges take the approach of being the market facilitator model, which is what most states wanted to do anyway. So it ends up that the federal default model sort of looks a whole lot like what most state-based exchanges probably would have looked like, and the states aren't on the hook for running the exchange 2015 going forward. So I think it's pretty reasonable that so many states took the federal exchange approach rather than doing it themselves. So let's take a minute and sort of talk about that financial feasibility issue. And what I've done here is sort of look at what Alabama considered when it thought about being a state-based exchange. And the Department of Insurance contracted with a consulting firm to help with all this. I should say up front that I was a consultant to the consultants, but I wasn't involved in any of these numbers. Basically, what they said was the individual exchange could have as many as 500,000 people in Alabama, and the small group exchange, the shop exchange, could have another 600,000 folks. But obviously not everybody is going to take that coverage. Even though they're eligible, they may already have coverage. They may choose to pay a penalty. So their best estimates were that, at least their mid-range estimates, was that about 60% of those eligible would take the individual exchange. About 5% would go through the small group exchange. That 5% may strike you as surprising, that so few small employers would sort of go that route. That's probably a high side estimate. In Massachusetts, we're looking at well less than 2.5% of small employers playing in the small group market. Most of the action, almost all of the action, is in the individual exchange. And in any event, the consultants estimate that in Alabama by 2015, when things were pretty much sort of rolling along, we could see roughly 330,000 people enrolled in an exchange. So what would it cost? And they went through sort of estimates of sort of what it would cost to do the eligibility determination, about $17.50 per enrollee. Then they have to actually enroll folks. They think the annual cost of that is something like $96. They've got the outreach and marketing. Part of that is those navigators things. That would be another $4 million. They've got to have staff, $2.5 million. They've got to have a place to have offices, $300,000 maybe, for a total of about $44 million per year. And you got to pay for that. Now, one way a state could pay for that would be to simply take the money out of the general fund. Alabama certainly wasn't going to do that. Most states weren't going to do that. There are a variety of ways. You could take tobacco money, I suppose. But what most states considered doing was to impose a fee on people who either bought coverage through the exchange or who bought coverage in the individual or small group market, regardless of whether they got it in an exchange. The estimates for Alabama are that if you went only those who bought coverage through the exchange, we're talking about a fee of about $11, a little more than that, per enrollee per month to pay for the cost of the exchange. That turns out to be a little bit less than what Massachusetts ended up costing, And if you do sort of back of the envelope estimates on what the federal default costs are, that's about the same ballpark. So we've got the exchanges. What's likely to happen to premiums? Well, that depends. It depends on three big things that go on with respect to the exchanges. First, we've eliminated medical underwriting. That meant those pre-existing condition clauses don't matter. It turns out that gender differences don't matter anymore. I mean, this year, if you were buying coverage and you were 30 years old, you would be quoted different premiums depending on whether you were a man or a woman. Women use a lot more health services. Their premiums are higher. Men, as we all know, go to the doc less. Well, you know, the bad news is we die earlier. The good news is our premiums were lower. Well, now you have to charge the same premium. And there's limits on age differences. The age range in premiums is something in the order of 1 to 5 from the lowest to the highest. Well, the law says it can't be any more than 1 to 3. That means that there's going to be sort of big changes in sort of the ebb and flow of premiums. So there are a variety of different estimates that are coming out now, and you've seen stories of premiums that are way high and some premiums that aren't so high. But basically, you've seen sort of stories, and we won't know until people sort of fully enroll and the dust clears what happened to average premiums. But there's sort of two things that I think we can say. This summer, the Society of Actuaries came out with some estimates, and they're probably the best estimates out there, at least the best that I've seen. And what I've put up on the graphic are the states that are expected to have the biggest increases in average premium, with Ohio and Wisconsin at the top of the list. Alabama is expected to come in at an increase of about 60%. The national average is about 30%. On the other hand, there are states like Vermont, Massachusetts, New York, where premiums are actually average premiums are actually expected to decline in the neighborhood of about 12%. What's going on? Two things. One, if you look at the pre-Affordable Care Act column, you'll see that those states that have the biggest increases currently have the lowest premiums. And the states that have the smallest increases have much higher premiums. Part of what's going on there is what state laws have done in the different states. In states like Alabama and on the top part of the chart, those are states that allow medical underwriting. You can get a lower premium if you're healthy. You pay a higher premium if you're less healthy. The states like Vermont, for example, have eliminated medical underwriting. So they've already said that if you're sicker, you can't be charged a higher premium. So that's why their premiums are higher than ours are today. And so think about that now as you move into an Affordable Care Act, which says everybody has to buy coverage. In the states on the top part of the graphic, those that have low premiums now, disproportionately those states have healthier people in their insurance plans, so the premiums are low. Now, disproportionately, you're going to see sicker people joining those plans because they can't be charged higher premiums. So you see sicker people coming into those plans, so the premiums go up. In contrast, the states on the lower panel, many of those have eliminated medical underwriting to start with, so they've already got the sicker people getting coverage, and disproportionately what they see are young, healthy people buying coverage because the mandate requires them to. So you've got less expensive people joining the pools there, so the premiums don't rise as much or decline. So it's the interplay of sort of what the medical underwriting rules are together with the mandates that sort of lead to very different results across states. So what you want to appreciate is you can't generalize from another state. You got to only look at your own state, and things will change all over. And at least for policy wonks like me, it's going to be fascinating just to sort of see to what extent these kinds of predictions hold up. What can you say about an Alabama exchange, and indeed any exchange that's sort of currently on the low end side? In Alabama, we see a federal default exchange, as the majority of states. Open enrollment started this month. In Alabama, expecting something like 330,000 enrollees. Average premiums may increase substantially, but some will see lower premiums. I mean, a good example of somebody likely to see a lower premium is there's a married couple who have retired, one spouse is covered by Medicare, the other spouse is covered by continuation coverage through a former employer. It's called COBRA. COBRA's expensive coverage. Chances are that spouse will be able to get much cheaper coverage to the exchange. A 26-year-old male is probably going to see premiums that go up substantially. Okay, that's the first half. That's the exchanges. The other way that they're going to expand the coverage and reduce the uninsured is through the expansion of Medicaid. Now, what the law said essentially was that all the states were required to expand their Medicaid program. They didn't actually have to, but if they chose not to, what would happen is they would lose all of their federal dollars for Medicaid, all of their dollars for their existing Medicaid programs for kids, all of their matching dollars for their CHIP programs, all of the matching dollars for dual eligible seniors and disabled. This was the part that the Supreme Court said, that's overreaching. In fact, what they said, it was the equivalent of holding a gun to the head of the states. And so what the Supreme Court said is you can't enforce that requirement. You can't put that kind of onus on the states. And the consequence was the states are now free to choose whether or not they wanted to expand their Medicaid program. But the incentives to do so are pretty strong. With respect to the claims costs of Medicaid, in the first 3 years, the federal government would pick up 100% of the claims costs of the newly eligible. And the newly eligible are those aged 19 to 64 who have incomes below 138% of the federal poverty line. So ultimately, by 2020, the federal government would pick up 90% of the costs, and the states the remaining 10%, and that ratio was supposed to continue off into the future. So as it stands, there are some 26 states who are participating. These are numbers from the middle of the summer. Some 26 states who were participating in the Medicaid expansion, some 19 states that were not participating or leaning against. But things happen all the time. Missed in the government shutdown and all of that at the beginning of the month was that the Arkansas plan for a waiver to let Medicaid expansion folks participate in the exchanges subsidized was approved. It turns out just yesterday Ohio decided that, although it clearly is going to be litigated, that Ohio decided that they were going to expand, to take the Medicaid expansion. So all of this is very much still in flux. Alabama has not expanded its Medicaid program, and the states throughout the Southeast have for the most part, decided not to expand. Well, what my colleague David Becker and I did was to spend some effort sort of looking at what an expansion might look like. And so we look at the period 2014 through 2020, the first 7 years. This graphic sort of suggests that over that time period, if everybody who was eligible for Medicaid participated in the average year, we're talking about a little bit less than 500,000 people. Not everyone does. We took the estimates from the Urban Institute, which is the dark line in the middle, about 300,000, a little less than that every year, would likely to be newly covered by an expansion of Medicaid. That costs some money. Most of that money is picked up by the federal government. The remainder is picked up by the state. The state in the first 3 years has no costs associated with the medical claims. They do have to pay their share of the administrative costs that go with these new folks. So even in those first 3 years, every state that expands has to pay their share of the administrative costs. It's about half of the administrative costs. In Alabama, our estimates are about $39 million. But over the 7 years, our estimates are that Alabama would spend $771 million for its share, and the federal government would provide almost $12 billion worth of spending. That's just the beginning of it, though, because it turns out that those direct dollars get spent again. I have to expand my practice to care for more people, so I hire some nurses and some technicians and some more administrative staff, and so I pay them. They go out and they buy groceries and they buy clothes, and that leads to what's called indirect spending. Our estimates are Alabama and most states like us sort of don't have diverse economies. So a lot of the dollars sort of leave the state pretty quickly. You buy gasoline, much of those dollars go to Louisiana and Texas because that's where it was refined and produced. So our best guess is that the indirect spending is another sort of 65% or so of direct spending. And so we see a major economic impact in terms of increased spending over these years. An estimate of almost $20 billion in total sort of new economic impact as a result of the expansion. That economic revenue generates tax dollars. Our estimates are, looking at the Federation of Tax Administrators, the Alabama tax burden is about 8.6%. That includes state income taxes, corporate income taxes, sales taxes, property taxes, all those set. And so basically what we conclude is if the state wanted to sort of go forward, it would, over those 7 years, it would spend some $771 million. It would get tax revenues of $1.7 billion for a net gain in tax revenues across the various taxing authorities in the state of a net gain of $935 million. So there's a big economic impact of expanding the Medicaid program, largely because of the very large sort of federal contribution to the expansion. So that's the economic case for expanding. There are reasons not to expand. And I think there are sort of three sort of key ones that a state sort of has to put into its calculus. The first is that the state doesn't necessarily have the money. It's sort of the, you're a new couple and you'd like to buy a house. Interest rates are low, housing prices are still low, but you got to come up with a down payment. And so the state in Alabama would have to come up with that $771 million. So that's a reason not to. Second, there's a concern that the federal government won't continue to pay its 90% of the medical costs. The legislation says it will, but there's concern that perhaps they won't, and then the state would be on the hook for the remaining costs. And then the third argument that I think also has credence is that it sort of steps out of the state's perspective and it looks at it more broadly and says, well, look, the ACA was a bad idea in the sense that we actually can't afford it, and so we shouldn't be doing this. So there are legitimate arguments for not wanting to expand it. I think there's an awful lot of strong economic reasons to do so. I should point out what happens to the exchanges in a state like Alabama and the Southeast where they don't expand Medicaid. Well, what happens is folks are sort of left in a hard place. Remember, those subsidies started at 100% of the federal poverty line. If you had income below that, the presumption was that you would be in the expanded Medicaid program. But if your state didn't expand it, you don't get the Medicaid program and you're not eligible for a subsidy. Now, what HHS has said is for those folks with incomes below 100% of the federal poverty line in states that didn't expand, they're not required to buy coverage, but they're not able to get coverage through Medicaid, and they could buy it through the exchange, but not with a subsidy. Finally, and very quickly, these are the CBO estimates again from 3 days before the legislation passed. All of this was supposed to cost something like $871 billion through the first 10 years, through 2019 from their numbers. Almost half of it goes for the exchanges. Almost half of it was supposed to go for Medicaid expansion. A little bit comes from that small employer tax credit, but as I say, it wasn't supposed to be a big deal. It's paid for by dollars drawn out of Medicare and by taxes on a variety of places. The expected revenues were over $1 trillion, and the argument was that this would reduce the deficit, even though we're spending more, but collecting more as well, would reduce the deficit by $143 billion. Time permitting, we would talk more about these, but we won't. Let's go to discussion and questions.
Does our audience have any questions? I've heard a lot of stories about difficulty accessing the exchange. Do you know how access to the exchange is going in our state in Alabama?
The short answer is no. Alabama is one of the federal default states, and the federal government hasn't released numbers on how all of that is going. Late last week, the Wall Street Journal was reporting on the state-based exchanges. Washington State seems to sort of be the star so far. It's apparently enrolled some 46,000, 47,000 people. Connecticut has enrolled some 13 to 14,000. Minnesota a little bit less than 4,000. So they're coming along, but very slowly.
Okay. One of the things I'm curious about, as you talked about the Medicaid expansion in Alabama not participating in that, is some of the conversations that we've had among peers has to do with some of the southern states being the more impoverished states. Is that true in your assessment?
Certainly. I mean, Alabama and Mississippi, certainly as is well known, have some of the poorest folks in the country. We're not alone in that, but clearly the region has a lot of poor folks and a lot who would be eligible for Medicaid expansions and for subsidies.
About how much time would it take someone to complete the application process?
Yeah. I asked a research assistant to sort of, as this started, I wanted a sense of how all this would go for Alabama. So I wanted her to sort of go to the website 3 times a day, see if she could get in, how far she could get. Couldn't get in till this week, and was able to sort of get to the first step, which was to submit an application, but wasn't yet able to sort of see the kinds of policies that might be available. What I've been telling people is, take a deep breath and don't try to go now. Wait till Thanksgiving or a little bit before. And it's about that time that if they're going to get the glitches worked out, they're going to get them worked out by then. Then you've still got 2 to 3 weeks to enroll. If you're enrolled by December 15th, you are supposed to be eligible for coverage as of January 1st. So you've got time. Let's see how they do.
I believe that we have a call from Montgomery County. Caller, are you on the line?
Yes.
What's your question?
My question for Dr. Morrissey is this. He mentioned that on average he expects premiums to be higher on the marketplace than in the current market. But I wonder if he or anyone else has done any research on taking the subsidies into account by income statistics to project what the out-of-pocket premium cost, the discounted cost, will be for average Alabamians on the marketplace as compared to the current market.
Yeah, certainly I have not done that. I don't believe anyone has done it for Alabama, and I'm not sure that it's been done nationally either. You have to end up making an awful lot of assumptions to be able to get to that sort of number. Even the sorts of numbers that we put up from the Society of Actuaries, they have to make some assumptions about, for example, among 30-year-olds, how many men, how many women are actually going to participate, because that sort of chips the premiums one way or another. If you further then have to go, how many of those are eligible for subsidies and how big are the subsidies that they're going to be eligible for, and fold all of that in when you didn't know what the price of the plans were going to be. Even for economists, that's a stretch into too many assumptions. So I haven't seen those sorts of numbers out there. One would expect that folks with low incomes, are going to end up paying something out of pocket for coverage through the exchanges. They'll be remarkably less expensive than what they would have paid for earlier this year. But as we're seeing as well, a lot of people are saying that the premiums that they're being faced with are much higher than what they've paid in the last few years. And we're really not going to know until the dust settles in terms of people who have actually enrolled and what premiums they pay and how all of that has played out. So The short answer is we don't know.
Well, thank you. If I could just make a comment, I worry that as an advocate, I worry that one of the public relations challenges we face is that there's a lot of attention being focused on the premiums themselves, the full list price, without factoring in the subsidy. So I just hope we can keep connecting those at every opportunity.
Yeah, and I think, it's a challenge in a state like Alabama that sort of doesn't have a state-based exchange and isn't doing the Medicaid expansion, and that's approximately half of the states. That sort of word doesn't get out. If you have a state-based exchange, you are actively sort of doing a lot of marketing about the nature of that coverage and what the prices are likely to be. In states like this, it really is going to depend on the advocates to be able to sort of tell that story, I think.
Thanks for taking my call. Great presentation.
Professor Morrissey, it looks as if we have a call from Pittsburgh. Caller, are you there?
Yes. Yes, I have a question from Pittsburgh.
What's your question?
My question is, how does the Affordable Care Act affect people who are on Social Security disability through the Medicare and who have to buy a supplemental to, get the other benefits such as the prescription, and they're under 65?
Yeah, the basic story is that if you are disabled, you're under age 65, you are eligible to participate in the exchanges. But the broader point that I think is important as well is that if you're on Medicare now, this is largely irrelevant to you. You are not going to be. You do not have to participate in the exchange. The Medigap policy that you may be purchasing is an altogether different animal than what we're talking about in the exchanges here. It becomes a little bit confusing because the open enrollment periods overlap here, and so seniors and folks eligible for the exchanges are sort of, in the press at the same time, but in very different sort of settings. But I wanted to assure that most seniors are unaffected. There's a group that will be over time. If you're in a Medicare Advantage plan, it's likely that over time you will have less choice and higher premiums there. But that's because one of the ways that the Affordable Care Act was paid for was to draw a fair amount of money out of the Medicare Advantage program.
Okay, but would I get better coverage going if I was eligible for the Affordable Care Act versus buying a supplemental?
Well, if we're talking about someone over 65, you're not eligible to participate in the exchanges. It's for people under 65. If you are disabled in that category, I think you would be well advised to chat with one of those navigators to tell you a bit more about exactly sort of how all that plays into your circumstance.
Great, thank you.
I believe we also may have some email questions. Will, if you wouldn't mind providing us those questions.
Sure. One question is, why does Alabama only have few or maybe even just two of the health insurance companies participating in the exchanges, and what effect does that limited choice have on Alabamians and the potential costs of the insurance?
Yeah, it turns out that at least from press reports, Alabama has the fewest number of plan offerings available in the exchange. As I understand it, currently we have Blue Cross Blue Shield of Alabama plan offerings and Humana plan offerings, at least on the individual side of the market. The hope was, and maybe it still is, that what would happen in the exchanges is that these would facilitate competition, and indeed they may. I think what we're seeing, to some extent, is if I'm a national player in the health insurance world, I'm going to look at the various markets that I can enter, and I'm going to sort of think about where it's likely that I'm going to be able to enroll, reasonably large numbers of people for the same sort of dollar amount. And I think the problem that immediately sort of faces insurers when they look at Alabama is they see Blue Cross Blue Shield and its very large market share, and they say, I'm going to have to devote a lot of resources probably to sort of marketing my product relative to, say, offering that same product in neighboring states. And so I think it's that concern about how much I'm going to have to spend on marketing to overcome the market position that Blue Cross has that has led some to at least think that they're not going to enter right away. I should say one of the things that this does do, though, is for the plans that are in the exchanges, you are able to see the sort of the side-by-side comparison, which is sort of the beginnings of being able to make sort of knowledgeable comparisons across plans. So it'll be interesting to see to what extent the Humana presence, for example, affects the enrollment choices.
One more question. Can we expect a huge hike in our taxes from the ACA as in other countries such as Germany, where they pay approximately 40% of annual income tax?
Maybe, I think, is the safest answer. If we had played through those financials that I talked about at the end of the presentation, I mean, what becomes abundantly clear is much of the funding that comes out of that is well, smoke and mirrors. That there was supposed to be a reduction in payments to physicians under Medicare. That hasn't happened, and the Congress has extended that exemption for a while. They will be visiting that again in the next round of budgets. We currently are not paying for the costs of Medicare or the cost of the other entitlement programs, and we've added this one on top of it. Ultimately, the piper gets paid, and this is another of the pipers.
We do have one more from email. If my husband has insurance through his employer, am I and my kids still eligible for affordable health care, or is it strongly suggested for my kids and I to be a dependent on his policy? What would be the pros and cons of that?
I believe you as dependents have the option. I think I would look very carefully at sort of what you have to pay for family coverage, or dependent plus one, or dependent plus two, however that is, and compare that to what would be available to you as one or two or three individuals through the exchange. In some cases, it's going to cut one way. In some cases, others. I suspect for most people, they're going to end up finding that it's cheaper to stay with the employer plan.
I appreciate your advice on telling us a good time of when to go and actually go online and look at the application and that type of thing. Can you tell us when the open enrollment deadline will be ending? Yeah, open enrollment runs through March. And if I remember correctly, if you're not enrolled by December 15th, if it's after that, your next opportunity to start getting coverage is February 1st. And after that, the next opportunity would be March 1st. And I know that you talked a lot about the economic impact of the Medicaid expansion. Can you tell us what that would have meant for jobs in the state of Alabama? Yeah, the University of Alabama School of Business recently released a report sort of looking at all of that. And in round numbers, using the same sort of middle of the road estimates that we used in terms of enrollment, their estimate is something like 30,000 new jobs. About a third, a little bit more than that, are in healthcare, sort of more nurses, more technicians in that. Another 20% or so is in additional retail employment. Another 18% is in professional and technical, and a smattering elsewhere. But the estimate is about 30,000 additional jobs in Alabama. Does our audience have any questions before we begin to end our program? Do you have any closing comments? I think we're at the crossroads of the exchanges now. It'll be interesting to see what happens between now and Thanksgiving. If you'd have asked me last week, I'd have said that maybe there's a 1% to 2% chance that the exchanges would be, or the individual mandate would be delayed a year. Now I think maybe we're in the neighborhood of 25 or 30% chance that that'll happen. I think it depends on how quickly the glitches or worse that we're seeing in the exchanges can be sort of dealt with. And if they're not sort of dealt with by Thanksgiving, I think we're in a position where people will think the unthinkable. Are there any really fun debates that you've had with colleagues in regards to this issue?
I think that the real issue isn't so much the debates as just the broad scope of things that are involved in the Affordable Care Act and all of the different sorts of folks that are likely to be affected. Hospitals, physicians, advanced practice nurses, what happens to employers as I'm an individual. I mean, my group of colleagues are analysts more than sort of political types, and so we spend our lunchtime sort of wondering about, what does this mean for, and what would that mean, and then how would you test that? But that's because we're policy wonks.
Right. Intellectuals.
Policy wonks.
Sounds like a lot more fun than some of the conversations that I've had. So are there any other questions? All right. Well, I want to thank you so much for your presentation. It's been extremely helpful. I was actually very excited to be coming down here and participating because there was certainly a lot that I've learned today. And we want to thank you all for tuning in to the Public Health Training Network. Please also be sure to fill out those sign-in sheets for those CE credits. And there will be information at the end of the program with regards to email addresses and phone numbers.